Thank you, Mr. Chairman, ladies and gentlemen, Barry. Thank you for inviting me to this very special session. And I would like to start off with a well-known issue, and this is the fact that athletes are seen as the healthiest segment of the society, as we all know. Sudden death is a riveting issue with high public visibility and concern, in great part media-driven. And as you all know, there is now an ongoing debate of the ways to prevent these tragic events. As we were shown in the past already, the rate of sudden cardiac death in athletes is highest in the US in basketball and football players, is higher in men than in women with a ratio of about 10-1, and it's higher in black athletes, particularly in the area of diseases which are associated with the highest mortality from sudden death in the United States. And as we learned already in the 80s from Barry's papers, the principal reason for sudden cardiac death in young athletes below the age of 35 is hypertrophic cardiomyopathy, whereas in those above this age is by far coronary artery disease. And this did not change in his recent paper published in 2009 in the largest cohort of patients with sudden cardiac death, as you can see in this picture. So the rationale for cardiovascular preparticipation screening in this problem which we have of sudden cardiac death, it relies on a few very important issues, which are that the majority of athletes with sudden death do not have premonitory symptoms. Athletic activity is associated with increased risk of sudden cardiac death, a transient but clear increase, as Domenico Corrado showed in a JCCC paper in 2003. About 90% of athletes dying suddenly do so in relation to intense physical training or competition, or during or immediately after. And about 90% of the non-traumatic sudden deaths in athletes are related to a pre-existing cardiac abnormality. So the common ground started on in the Bethesda conference, 26 Bethesda conference, which took place in 94, was published in 96, and which stated that cardiovascular screening for young competitive athletes is justifiable and compelling on ethical, legal, and medical grounds. And this sentence actually opens the recommendations of the ESC about 10 years later in 2005. So why and on what issues is the debate going on? The simple and the incorrect answer which most cardiologists in the world will give is that the culprit is the ECG, and the point of this course is the ECG. I will try very hard during this short lecture to show you that this is not correct. And the first point I would like to make is showing you that this very important information, which is the prevalence of cardiac diseases, which will confer a risk for sudden cardiac death in young athletes, or have the potential to confer sudden cardiovascular death risk. And as we all can see from these different papers, there is an average of 0.5% cumulative risk of having a potentially lethal condition, which should be detected during pre-participation screening. So basically a low prevalence for many etiologies, including, amongst others, cardiomyopathies and ion channel diseases, channelopathies, which basically are considered to be detectable by electrocardiogram. And on this map, which I thank for Barry providing me with, I added a few issues, and this is actually the major question which I would like you to believe me, it is my conviction, is the major issue and not the ECG, which is at the bottom of the controversy. And the question is, how frequently do these rare conditions kill athletes? And in this, there is indeed the difference between Italy and the United States, or so-called Italy or Europe, but basically things really restrict to the Veneto region and to Minnesota, where most of the information we receive from. And the difference between these two perceptions is completely different. The incidence of sudden cardiac death is different by the way it was found in Minnesota than in the Veneto region. And we have here two extremely important points. This is the numerator, which is 1, and shows you the number of athletes who actually died during the follow-up period, wherein this is the denominator, which showed the total number of athletes which were active that time during athletic activity during the period you followed them. And when we will have an absolutely adequate and foolproof number for the frequency of the rare conditions who kill the athletes, we will know what is the best procedure, 100%, to do the pre-participation screening. Until then, we have some problems. So everything started off here with this Bethesda conference, as we just heard, which was followed later on, just a little bit later on, is 2007, by an update on the recommendations, which say by the AHA that you have to have a family history, a personal history, and physical examination, and this is the pre-participation screening if everything is normal. Here is the ESC recommendation. By the way, these are not guidelines. I would like you to pay attention to that. Are recommendations and consensus documents. And this is exactly the same, except that we have the 12-lead ECG here. And this was implemented, as we will see, in Italy in 1982. And it was very methodically performed in the Veneto region, in Padua, where the leader of this process was Domenico Corrado. So what happened with this recommendation, as you can see from this summary, recently published ahead of print in the European Heart Journal. Here they summarized 12 countries, European countries, you don't have to read them. All of them have ECG recordings as either recommended or required, but the ones with the stars are 4 countries where you have, in addition, either required or recommended exercise test and or echocardiography. Israel, if it would have been put on this slide, we have the same baseline, but we have actually also exercise test required, requested, and it has to be done by law, like in Italy. So there is a large heterogeneity. And then now we go back to the controversy and let us see why the recommendations come from Italy in the way they come and to the ESC. So the first piece of information was published in this paper in the New England Journal, where they summarized their experience in 33,000 athletes, of whom 3% were disqualified. This included 22 patients with athletes with hypertrophic cardiomyopathy who were disqualified, and none of them died during an 8-year follow-up period. Only 23% of these patients would have been identified by without an electrocardiogram. So 75% would have gone into active athletic activity. And here are their major results showing that what they found, that the major reason, in contrast with what we have seen in the United States, in the Veneto region, the major reason for dying suddenly an athlete was ARVC, and not hypertrophic cardiomyopathy. Actually, only 1 patient died of hypertrophic cardiomyopathy, and their explanation was that they were able to diagnose hypertrophic cardiomyopathy and prevent athletic activity being performed by them. And here is a 29-year-old soccer player who died suddenly during game, even if his participation electrocardiogram should have raised questions about ARVC. And the next slide shows that the same group from Padua showed that the sensitivity of 12-lead ECG in sport-related sudden death victims with ARVC in their experience was 88%. The next case is one of a 21-year-old basketball player with hypertrophic cardiomyopathy who was identified by pre-participation screening. And we learned in the past from a paper coming from Bari that the sensitivity of 12-lead ECG in sudden death victims with hypertrophic cardiomyopathy is actually 96%. So this was the first piece of information on which the ECG addition is based. The second came in this JAMA paper where the authors from Padua compared the incidence of sudden cardiac death before and after the enactment of the Italian law, and you can see that there is a 90% decrease in this incidence, while people of the same age had an unchanged graph of incidence of sudden cardiac death. And this looked very impressive and significant, even if already at that point quite some literature was going around about the dark part or dark phase of the electrocardiogram, and this was the difficulty in distinguishing it sometimes from athlete's heart. And this is quite a remarkable case in which we can see that the athlete here during peak season has very significant electrocardiographic changes, whereas off-season the changes are much less impressive. So the same author, Sanjay Sharma from England, also found recently published on the extensive changes, mainly in black athletes, in their electrocardiogram, about which we have to learn much more, and this is much more significant than in white athletes. So based on all these shortcomings of the electrocardiogram with the false positive results, very recently the ESC came up with these recommendations for interpretation of 12-lead electrocardiograms, about which I would just say that they divided them in two groups, and in the first group you have 80%, which is very common and it's benign and should be known by everyone who deals in this subject, whereas on the second group have what they consider being less than 5%, is a long list of pathologies which have to be evaluated further, and on the first place by far is the T-wave inversion. And the authors also believe that if these recommendations will be applied, they will reduce the rate of false positive ECG by about 70%. Now, what is the perception after all this in the United States? So this study was published by Bari in 2009, and he compared Domenico's results with his own results in Minnesota, and what he found that actually there was no difference between the two groups, even if the Minnesota group did not have electrocardiographic screening. But there was, however, a question about this bump, this very high incidence of sudden cardiac death in the era when just the screening was started. And the answer and the concern coming from the Padua group, which they published concerning this article, was that actually the athletic populations were not identical, and it is true that the Bari's athletes were younger and he had more female athletes in his group. But the major issue was the different methodologies, whereas the Italian group was a prospective study, at least starting from the point when the law was enacted. It included all deaths and included all athletes screened, and it was evaluated the pathology in a very experienced single pathology center in Padua. The study coming from the United States was retrospective and mainly a media review. And here comes into the picture our small country, Israel, by this publication coming very recently being published in JCC by Steinwil, Wiskin, and colleagues from Tel Aviv, and is based actually on the fact that since '97 we have this Israel sport regulation, which is based, in addition to the other components, on exercise test. The number of deaths was, again, like in Barry's paper, mainly from the media review, actually practically from media review. And the athletes at risk, the nominator and denominator we are speaking about, were in this case also extrapolated from the 2009 census. The authors did something which was not done in previous papers, and they looked to the findings for 12 years after, which were available after the enaction of the law, but they also went back 12 years in the past. And their findings were quite interesting, because what they found that there was no difference in the number of sudden cardiac deaths between the two periods, having this prominent unexplained number of large sudden cardiac death episodes just before starting the law, very similar with what Corrado actually found. So their conclusion was that the ECG screening of athletes had no apparent effect on their risk of cardiac arrest, which I really cannot understand. I believe that they should have written that the screening of athletes had no apparent effect on their risk of cardiac arrest. Why only the electrocardiogram had no effect? But they did one thing, further thing, which actually no other person did before, and this was that they compared the 12 years followed after the enaction of the law with a second calculation of what would have happened if they calculated only 2 years back before the law was enacted, and they got a very similar curve with the Veneto area curve. And they also, from this finding, came up with the hypothesis that perhaps both in Israel and in Italy there was an unexplained increase in the incidence of sudden cardiac deaths, and this actually led to start of the pre-participation screening laws both in Italy and in Israel. So let me just come back to this controversy of the estimates, 1 in 220,000. Is this the only information we have from the United States? The answer is no. This paper was published just a few days ago, coming from Harmon, Dresner, and colleagues, who evaluated prospectively 5 years of sudden death recordings, and they, using different methodologies, they found 45 cases of sudden cardiac deaths amongst National Collegiate Athletic Association athletes. And these were found mainly by, in a higher proportion, using the database, which is an obligatory database reporting, 87%, whereas media search only revealed 56% of the cases, and catastrophic claim data only 20%. But the major information is in this slide. What they found that the sudden cardiac death rate among these young athletes was 1 in 43,000 participants per year. And if you look specifically to the group of high elite basketball players, it was actually 1 in 3,000. So I would like, Barry, to ask you, if you were a star basketball player, which we all can see here that you were, with a 1 in 300,000 chance of sudden cardiac death, would you like to have an ECG done? You can tell me that near a coffee thereafter. So the incidence of sudden cardiac death, which was found 1 in 40,000, is not very different from the numbers found, some of them from the United States, in 1 in 25,000 and 1 in 58,000 in previous reports, also originating from the United States, but not prospectively done, like it had been done here. So let me now show you this slide, which I thank again to Barry for giving to me, because I would like to emphasize issues beyond the ECG as they are perceived in the United States, and we perhaps until now didn't really understand them. I certainly not. The first issue, which I marked here in this special color, is that the basis is customary practice in the United States and is low in Italy and, by the way, also in Israel. The examiners are MDs and non-MDs, like chiropractors, nurses, and so on, whereas in Italy are accredited sports medicine specialists who specialize for 4 years, not only in cardiology, but general sports physicians. And there are legal consequences which are not discussed at all in the Italian literature. Then, therefore, the obstacles to the Italian screening initiative in the United States ranges actually between 2 points of a perceived very rare incidence of sudden cardiac death and the fact that no one can perform examinations and interpret the ECG today in the United States in the numbers required. Only for the young athletes would be 15 million persons, and if you consider the fact that by the law you cannot limit yourself and discriminate athletes and not do it then in entire the same age population, you will reach really astronomical numbers without having the personnel and infrastructure to tackle this problem. So I would like here to show this picture in order to introduce my last point, and this is Barry in 1983 visiting for the first time Venice. And as you can all see, he is quite content with the guidance of this nice lady who, and he follows very carefully what this guide from Veneto tells him. My point is that the AHA is not against voluntary practices and private practices based on guidance coming from the Veneto region. And this is very clearly written in the guideline, which people either don't read or don't understand. And in these guidelines from 2007, it is clearly written that also the ESC proposal is innovative and based on a generally favorable long-term experience in Italy. It cannot easily be translated in the US medical system and environment. It doesn't say that it's incorrect to use ECG. On the other hand, the panel does not arbitrarily oppose volunteer-based athlete screening programs with non-invasive testing performed selectively on a smaller scale in local communities if well designed and prudently implemented, like you have Harvard University, for example, to the best of my knowledge. This became probably also a highly emotional controversy, and from many citations, I kept only 2 because of lack of time, that if you don't have money in the United States, then here it's written that you should ask any parent how to get the money. And the second is something which is quite unusual to find written in an editorial, that some US experts had joined the cacophony in favor of more extensive testing. So I would like to finish telling you that it is my personal opinion that ECG should be included in the pre-participation screening because it is abnormal in a high proportion of conditions including hypertrophic cardiomyopathy, ARVC, WPW, long and short QT, Lenegre conduction disease, and Brugada. Genotype-phenotype correlations in cardiomyopathy show that ECG changes can antedate other clinical signs. And there is evidence that use of ECG reduces mortality in screened athletes, even if it's not foolproof. It's done mostly in a very controlled environment, and the proof is at least as strong as is the proof of the other side who oppose this approach. And my conclusion, therefore, is that more research and mandatory reporting are needed to expand our current knowledge regarding the mechanisms and strategies to prevent sudden cardiac deaths in competitive athletes. Pre-participation screening should include ECG at local or national level, supported by proper infrastructure and trained medical personnel. And I really believe that each country has to make his own decisions, what can tackle and what cannot tackle in this regard. And the last point is that indeed optimization of ECG interpretation is required to reduce the number of unnecessary tests and disqualifications. I would like to thank Marty Maron and Paolo Spirito for their valuable help of part of my lecture, which you probably realize which part was. Thank you.